Hello, nursing scholars. Today we're going to be discussing two things. We're going to be discussing bowel and urinary elimination. I've done my best to try to divide this into two parts so that the lectures aren't quite as long. So we'll see how that goes. Um, as you may probably already um, assume, that in most American households, without young children anyway, bowel elimination is actually really considered a pretty private matter. And in the healthcare environment, a patient's bowel elimination or the function or dysfunction thereof is evaluated and analyzed and discussed pretty frankly and openly. Elimination of solid waste products is a normal function of the body, but a patient may be pretty embarrassed to discuss their bowel elimination habits. So it's kind of up to us to create a nice environment in order to discuss that and to be frequent, pretty open about it. Bowel elimination, however, is very critical to maintaining our nutritional status as well as hydration and fluid and electrolyte balances. So, regular bowel elimination, especially in the hospital, may be disrupted by a various number of factors. The nurse must understand the physiological, or at least the physiological process of bowel elimination and some of the factors that may alter that elimination and measures to assist the patient in hopefully maintaining whatever is their um, normal bowel pattern, if you will. So I'm not going to give you an anatomy and physiology lesson, but just for review here, the GI tract is the body system that's basically responsible for all of our digestion of food and our absorption of nutrients and fluids. And this chapter will focus on the essential role of the GI system in formation and storage and elimination of waste products. So the GI system is a series of muscular organs extending from the mouth to the anus. It is a continuous loop or continuous tube. At least that's how I think of it. From your mouth all the way to your anus is a continuous tube, made up of various different types of anatomy and physiology. The esophagus is a collapsible tube, actually, that's connected to the pharynx, which allows the food to travel to the stomach. And then its primary function is to transport those solids that we eat and the liquids from the mouth to the stomach where digestion actually begins. So the food mixes in the stomach with the digestive juices, causing the chemical and mechanical breakdown of food into what we call chyme. And then prior to entering the small intestine, then the small intestines are basically their primary function is of digestive and absorptive functions. Intestinal juices and bile from the liver, the gallbladder, and the pancreas basically mix with the chyme and continue to help with digestion and the absorption of those nutrients. The large intestine is the primary organ of bowel elimination, um, and this is all achieved through peristalsis, which basically forces the chyme into the large intestine through the ileocecal valve, which prevents regurgitation of chyme. So peristalsis basically is the slow movement through muscular contraction and relaxation, which moves the food along down through the bowel system. The rectum, actually, where all this eventually ends up, has folds of tissue that temporarily hold these fecal contents. And then each fold contains an artery and a vein that can become distended from pressure during straining. And this distension can oftentimes actually result in what we call a hemorrhoid. So the sensory nerves in the anal canal actually help control the bowel continence. and the feces and the flatus are expelled from the GI tract through the anal canal and the anus. Um, Oftentimes, it's kind of a hard question to ask if you ask a patient if they're passing flatus. But however, flatus in the nursing world is gold. So if they are passing flatus, it's fairly safe to assume that their bowel system is working appropriately and is moving things along. That doesn't mean that someone can't be constipated. However, when we are advancing their diets, either whether it be post-op or otherwise, we want to make sure that they're passing gas. If they're not passing gas and or stool, that can be a problem. We could have paralytic ileus. We could have a lot of other things going on. So oftentimes, not only just listening to the bowel tones, we are also asking that patient when their last bowel movement was and if they are passing flatus. So the frequency and the amount of defecation varies amongst individuals, ranging from 2 to 3 times per week to several times per day, which several times per day would be uh, quite a bit. So it just depends on what their normal bowel pattern is. So we have to kind of dive into that and ask them how often do they normally have a bowel movement. When the peristaltic waste waves move the waste into the rectum, the nerves in the rectum eventually are stimulated so that the individual becomes aware that they need to defecate. And feces can be hard, they can be dry, they can be formed, soft, or liquid, and the characteristics of the feces vary depending on the diet and the illness and the medications and the age. So that's why we typically always document the appearance of the fecal matter. So many hospitalized patients are either at risk or have some type of alteration in bowel elimination. A lot of that has to do with obviously immobility, but it can also be disease processes. It can be effects of the medications that we have the patients on. But oftentimes it's the mobility issues. So that's why we want to get up and have patients ambulating and whatnot. Um, Abnormal defecation patterns include such things as diarrhea, and that is when we have hyperactive bowel sounds and they constantly have an urgency and abdominal pain and cramping, which are the characteristics typically of diarrhea. Um, Clostridium difficile can actually lead to life-threatening inflammation of the colon, and that's C. diff. You may also hear that, which is caused oftentimes by the overuse or constant use of antibiotics. The flip side of that from diarrhea would be that the patient is incontinent of feces, and that can also have a profound impact on a patient's body image. I mean, they don't like sitting in their feces, and we also have to be very um, cautious and very clean to prevent skin breakdown and whatnot. So, in many cases, the patient is alert, but they're actually just unfortunately unable to control defecation, and that's embarrassing for them. So we have to kind of create and let them know that hey, that's okay. Just work along with them and create the environment where and be professional about it because you will have patients that experience all of this. So I talked about also constipation, okay, which is a pretty common problem, which affects the quality of life of many individuals, and basically that involves a slowed intestinal peristalsis that we talked about earlier, and the fact that they have infrequent bowel movements that result in basically increased water absorption in the colon because it's slowed down. So, which leading to the difficulty of passing stools and excessive straining upon defecation. And for people with heart problems, that's kind of an issue. We don't really want them bearing down and having to strain when they are trying to have a bowel movement. That because that pressure from straining during defecation can induce elevations in intraocular pressure, increases in intracranial pressure, and which can sometimes actually cause cardiac dysrhythmias and hemorrhoids. So when they're bearing down, that's what we call the Valsalva maneuver, which causes an extremely rapid rise in blood pressure, which is typically followed by a fall in arterial blood pressure, and also it is decreases the heart rate and can cause bradycardia. If the feces are not passed, eventually we end up with what we call an impaction, which is the result of unresolved constipation. And over time, the stool becomes wedged in the rectum and the patient is unable to pass it. And then we have to go in and do what we call a digital removal of the impaction, which that's not a whole lot of fun, but it can be done. So in flatulence, like I said, flatulence is gold, which is a mixture of the all the gases that are being created when our food is being digested, and it's expelled from the mouth either in belching or the anus as in passing gas. So severe flatulence contributes to, abdominal distension and severe sharp abdominal pain. And sometimes all they have to do is pass the flatus or the fart, and maybe some of that pain will go away in their stomach. So some of the things that we do to help correct a lot of this, we have bowel diversions, which are created for certain patients with conditions that prevent the normal passage of feces from the rectum. The terms ostomy and or you hear it called a stoma as well, where we take part of the bowel and we bring it out through the abdomen and invert the intestine, and that we create a stoma. And those are often used, ostomy and stoma are oftentimes used interchangeably, although they do have different meanings. So a bowel diversion or ostomies are created to divert and drain fecal material. So that's, like I said, we bring it out and it usually has attaches a bag or a wafer to it so that the bowel contents can come out. Bowel ostomies are classified by whether they are temporary or permanent, and it also depends on their anatomical location and where the construction of the stoma occurred. So a temporary colostomy is used to allow the lower portion of the colon to rest or heal. So again, if we have an issue in a bowel, sometimes it may just require that we go ahead and rest the bowel. Or if we take out a segment of a colon or segment of the small intestine, in order for that to heal, we may have to create a double barrel ostomy and have them both come out. And then after a certain period of time, we can bring those back down and we can reanastomose those. So sometimes the bypass is due to a cancer, for example, and to allow that bowel to actually rest and not have its work going on. A temporary colostomy is used typically in the lower portion of the colon, and it's usually created in emergency situations. And temporary ostomies are designed to eventually, at some time, be closed, or like I say, take down and reanastomose them means put them back together. Permanent colostomies, however, are placed when there is a loss of a body part of the colon. Most commonly, that would be as far down as the rectum, and they are created as a treatment for colorectal cancer and or I should say and or after the lower digestive tract is removed due to illness or disease. So it depends on how much of the colon or how much of the small intestine we have to move. So there are different kinds of ostomies, and actually, if you look at the ostomies, based on just their anatomical location, you can kind of tell um, where it's at. You can also tell by the smell as well as the consistency of the feces. So if it's higher up in the ileum in the small intestine, you will see that the drainage is very liquid, and it cannot really be regulated in any way. It'll just constantly come out. And a transverse colostomy is created in the transverse colon, okay, resulting in one or sometimes, like I said, two openings, which would be a double barrel, what I'd call double barrel. The transverse colostomies produce like semi-formed liquid drainage, as some of the liquid has been reabsorbed, but not all of it, and it's not down far enough to where we're actually starting to create a feces or a bowel movement, if you will. The patient usually has no control over any of these. They don't have any control over the frequency of the discharge. So the appliances are in place at all times. Uh, I mentioned to you about the double barrel, and that is typically performed when two ends of the bowel are brought out into the abdominal wall, and the procedure consists of two distinct stomas. The proximal end is the functional stoma, and the distal end is the non-functional stoma. The bowel between the double-barreled colostomy stomas is surgically severed or removed, and I would say that that would typically be somebody with cancer, where we would have to do a colectomy, which is removal of part of the colon. In an ileostomy, for example, which is depicted here, the intestine is brought out through the abdominal wall to form that stoma. And ileostomies, they can actually be temporary or permanent, and they can also involve the removal of all or part of the colon. Stools from the ileostomy are frequent, and they're liquid, and again, the drainage cannot be regulated by the patient. This drainage usually contains digestive enzymes, which can be very damaging to the skin, and therefore ileostomy patients wear an appliance continuously and take special precautions to help prevent skin breakdown. We also have wound and colostomy wound nurses, and this is kind of their specialty, and they are very helpful in helping maintain those appliances and teaching the patient how to change them, as well as keeping them nice and clean and maintaining the appearance of the stoma as well. The ilio anal pouch is probably now the most common ileostomy, I would say. However, technically, it's really not an ostomy, since there's no stoma that comes out. In this particular procedure, the colon and most of the rectum are actually surgically removed, and an internal pouch is formed out of the terminal portion of the ileum. An opening at the bottom of this pouch is attached to the anus, so that the existing anal sphincter can be used for continence. This pouch is also called a pull through, or an endorectal pull through, or a pelvic pouch, or you may also hear it called as a J pouch. After the initial pouch creation, the patient has a temporary ileostomy to allow the anastomosis that the cutting of the two, to allow the anastomosis to actually heal. The coach pouch is a surgical variation of the ileostomy, and basically a reservoir pouch is created inside the abdomen with a portion of the terminal ileum. And then a valve is constructed in the pouch, and the stoma is brought through the abdominal wall. A catheter tube, a catheter and or a tube can basically be inserted into the pouch several times a day to drain the feces from the reservoir. So there are a lot of factors that can affect a person's bowel elimination. Elimination patterns can be altered in health, as well as when someone is sick or suffering from an illness. So the regular elimination pattern is specific to the individual. It is influenced by a person's age, their environment, where they grew up, and obviously what their culture is. Diet and physical activity, emotional health, and surroundings may impact elimination in either a positive or negative way. Diet is a probably, well, I would say it is the major factor that can affect the function of the GI system. Regular physical activity promotes peristalsis and facilitates the movement of chyme through the colon, which is why you'll see that post-operatively, one of the probably the most important things we can do is get that patient up out of bed and get them moving. That regular physical activity promotes the peristalsis and basically facilitate their bowels to get going and start moving things through the colon. Um, Psychological factors also affect the function of a person's GI system, as I kind of mentioned earlier. Uh, Anesthesia, um, post-operatively, it does affect the parasympathetic stimulation of the muscles of the colon, which causes our peristalsis to slow, or in some cases even to cease. So most people don't think of having a bowel movement as being a parasympathetic action, but it actually is. We have to be relaxed and in order to have a bowel movement. And I kind of use the analogy like a fight or flight. I mean, I know that if I'm scared and I'm running from a bear, I'm probably not going to be able to have a bowel movement at that time. Somebody would may say that scared the crap out of me. And the fact of the matter is, if you are scared and you're in a flight or flight, you're in a sympathetic uh, fight or flight, and you're probably not going to be able to have a bowel movement. So just remember that to have a bowel movement, you do have it is a parasympathetic stimulation, and you have to be relaxed. So, with regards to anesthesia, if people come out of surgery and we don't get them up there moving, and we're not able to advance their diet as tolerated, they can sometimes end up with what we call a paralytic ileus, and those can last anywhere from 24 to 48 hours. And that is where we would probably have to put in an NG tube, a nasogastric tube, which its primary function is to decompress the stomach and arrest the bowels. So if our bowels are not moving, we don't want to keep sending food down in there. It's just going to cause more of a problem. So they'd probably be NPO. We'd put in an NG tube. It would decompress their stomach, rest their bowel, and then at some given point, hopefully we'd be able to slowly advance their diet and get those bowels moving again. Also, a lot of the medications that we give, a good example is any kind of a narcotic or opioid. You can almost be rest assured that the other prescription that you'll see accompanied by that would be for colace or a stool softener of some sort, because we know that that's coming because of the effect of the narcotics. Cathartics are strong laxatives, and they actually stimulate the evacuation of the bowels by causing a change in the GI transit time, and those are called cathartics. So when we're doing our health assessment, and I would direct this more to like a focused GI uh, assessment, where yes, you want to look at the stomach, and then of course you want to auscultate, and then you want to palpate for tenderness or for firmness or whatnot. So, but we can also gather a lot of subjective data just from the patient. And on the slide here are some of the questions that you can ask that might help kind of elicit some of the information you might need. A focused interview would include past and present health history. Like I said, the physical inspection of the abdomen, and then inspection of the feces or lack thereof, and a focused diet history, including if they have any chewing or eating or swallowing difficulties, maybe what medications they're on, any illnesses that they have, and any kind of a food intolerance that they may have. So, while performing the bowel elimination assessment, okay, the nurse needs to consider the patient's physical, mental, and their functional abilities, as well as the patient's environment, family, and social support system, and also their culture. So there are some tests that we do. If somebody came in and they're having difficulties having bowel movements, or maybe they're complaining of bleeding at the rectum, which if the bleeding is bright red, I would be pretty rest assured that it's probably in the lower part of the GI tract. So I'd be thinking more of like a hemorrhoid, or maybe a rectal ulcer or something like that. If the blood is of dark color in their feces, it's probably higher up in the GI tract. Maybe they have a GI bleed somewhere up in there. But there are some basic tests that we can do, and one of those would be a fecal occult blood test, which basically measures for microscopic amounts of blood in the feces, and it can be a sign of a growth in the colon or the rectum, like I just said. So, getting that comprehensive history, which identifies the normal and abnormal patterns of their bowel elimination, and comparing them to the patient's perception of normal, is a pretty crucial step in identifying elimination issues. Remember that talking about these sorts of things can be kind of embarrassing, but if you have difficulty talking about this stuff, you're going to have problems with nursing, because we obviously need to get to the bottom of all this, and we need to be open and transparent with us as we ask those questions regarding the GI. So asking someone how many often, how often do they have a bowel movement? That's pretty personal. Or to ask them if they're farting or passing gas right now, that would be another question that should be in the forefront of my mind. So we need to make sure that we include any history that they can provide us, and that would include any kind of surgeries that they've had, or any kind of an illness that they've had previously, or even currently, anything that would affect the GI tract. Family history, unfortunately, is also another big part of this, and that needs to be evaluated, especially for GI cancers and things like Crohn's disease and ulcerative colitis and other GI disturbances with that may have some familial links. So, if somebody in their family has those, it can help us let us know maybe it's something that's hereditary that's going on. So prior to inspecting the abdomen, okay, we forget that the mouth and the teeth and the tongue and the gums are and any dentures that they may have or anything like that, or how the mucous membranes appear. That's starting the the head to toe assessment, and that's the first part of the GI system. So remember that the mouth is certainly part of what is assessed. We prefer the abdominal assessment to be performed, obviously, while the patient is in a supine position, maybe with a pillow behind the head and the knees, which takes some pressure off the back, kind of relaxes the stomach, especially for the palpation part. Auscultation begins in the right lower quadrant and then basically proceeds through each of the remaining quadrants. So diagnostic tests provide us some information about some of the alterations in maybe a patient's status, but it may have not been seen in the lab test necessarily. So an upper GI tract, or what we call something like a barium swallow, which is basically a radiological test that they do that defines the anatomy of the upper GI tract. They swallow basically a radiopeg dye, and we can kind of tell from that how it goes down through the esophagus and through the stomach and down through the duodenum. We also have the lower GI series, which is known as a barium enema, which is the same similar idea, except for it's going up through the rectum with a radio peg dye, and we basically get X-rays of the rectum, the colon, and the lower portions of the small intestine to basically help us in the diagnostic portion to identify maybe abnormal growths ulcers, polyps, or diverticuli, and even colon cancer. So we can also do an endoscopic procedure, okay, to basically help us view the inside of the esophagus. And we can also do a colonoscopy, which is up the rectum, and they basically take a camera, whether it be an endoscopy uh, or a colonoscopy, either one of them. It has a little camera on it, and we advance the camera down or up the digestive tract, and we're able to identify things. And oftentimes they can be operative as well. So if they have, they almost always will be taking some biopsies of some sort, um, of especially if there's polyps or anything like that. But they can sometimes take anywhere from 10 to 15 biopsies, and they will be labeled by their anatomical location of that biopsy. So where would we be without nursing diagnoses? Well, remember, nursing diagnosis basically just help us take our all of our assessment data that we've gathered and put them into something that helps us frame our nursing interventions and what we're going to do for these patients. So on this slide, basically, is just some of the nursing diagnoses that are associated with bowel disturbances or bowel abnormalities. And uh, in addition, some patients may just exhibit, maybe a risk for constipation or perceived constipation. So, although not directly related to elimination, the patient with bowel elimination issues may have also have associated nursing diagnoses such as risk for impaired skin integrity, like if they're incontinent of stool, or they may be at risk for fluid volume deficit and pain, for example. If they're not able to have a bowel movement, maybe they're having a lot of abdominal pain. So there are also some other nursing diagnoses that are associated with those besides, constipation or diarrhea or bowel incontinence. There can be some of the other nursing diagnoses that would also be associated with those as well. And so our overall goals is to basically reestablish whatever normal bowel function that patient has told us it is. If they say I have a bowel movement every day, hopefully we would like to try to achieve that for them while they're hospitalized. And again, any prevention of further complications. So we want to make sure that the patient will pass soft stools daily, for example. We want to say the patient will defecate form stools within 24 hours, or let's see what else. Episodes of bowel incontinence will decrease within 48 hours after starting a toileting program. So maybe we have them involved in a toileting program where we have them go ahead and get on the commode or on whatever to help stimulate them having a bowel movement. The patient will care for themselves after toileting within 2 days. So, and the patient will participate in personal colostomy care during hospitalization. So these are all very dependent upon the patient's situation and what is going on in terms of their bowel elimination and what their actual issue is. So, what do we do as nurses for these sorts of things? Well, we're trying to stick with what is evidence based practice, and fiber and bowel health are one of those things. So, the nurse we can help patients achieve regular bowel elimination by performing or assisting the patient with these techniques and promoting those habits of their regular bowel elimination. So, nursing measures to aid in that bowel elimination include interventions for diarrhea. We talked a little bit about constipation, fecal impactions, and or incontinence, as well as those for patients with bowel diversions, for example. So, after we assess the pattern of the patient's bowel elimination, and we determine that the patient's perception of what their normal bowel pattern is, we want to encourage them to reestablish whatever that regular bowel pattern was. And every patient with an elimination problem is weighed daily. Okay, and I would say that the daily weights is probably one of the things that is oftentimes missed. However, it is one of the most accurate ways, especially for measuring inputs and outputs, and whether or not they're retaining feces or whatever could be based or at least substantiated by their daily weights. It's a very important indicator of a patient's fluid balance status. People with dementia, acute confusion, maybe they have some mental retardation, and those are all obviously going to be risks for fecal incontinence, and therefore their mental status has to be monitored closely. And I typically think of your elderly folks for that, but just you need to determine, and some people may actually have a change in their level of consciousness while they're in the hospital, and that can also affect their ability to have bowel movement. So we we play with poop a lot. Okay, so we need to make sure that we wash our hands frequently uh, to reduce the risk of diarrhea from such things as foodborne or communicated illnesses. So as well as we have ourselves wash their hands and do their stuffs, we need to encourage the patients as well to wash their hands every time after a bowel movement. If they don't, they are at risk for developing some form of a communicable disease as well as any kind of a foodborne illness as well. Over in general, a diet that's high in fiber. I know we've heard that, and you'll see that, and you see it on TV and everything. To make sure and take foods that are in high fiber, and to make sure that we have adequate fluid intake. And when we talk about adequate fluid intake, that's at least 8 to 10 glasses of 8 ounces of water a day, which is quite a bit. But we need to encourage that because sometimes people forget to drink water, and in hospitals as well. Most of our sick patients are on some kind of a maintenance fluid, so if they're not having adequate intake, maybe their maintenance fluid needs to be increased to help the fecal matter and to promote their normal bowel pattern. So we it's up to us to make sure that we encourage patients, even your bedridden patients. Let's say that they're a high fall risk. We would want to make sure that we encourage them that even though they're supposed to stay in bed, we have other things such as commodes and such as bedpans that they're going to have to use, and you're going to have to also learn to use those. So we want to encourage the patient to be out of bed at as soon as possible after surgery, but we also want to balance that with their risk for falling or if they have a severe illness. So if they're really sick and they can't get out of bed, then that's when things such as bedpans come into place. Exercises, it could be as simple as turn, cough, and deep breathing, changing positions in bed, or we may have them be doing passive or active range of motion exercises. All those, any kind of activity like that increases peristalsis and help prevent constipation. So even if we get a patient up out of bed, even walking 10 to 15 minutes per day um, has actually been shown to increase their digestive function, believe it or not. So it doesn't have to be that they're working out to a sweat, but we need to get them up and get them moving around fairly quickly and as soon as possible. The We as nurses are often the one who assist these people in getting up out of bed and achieving that regular bowel pattern by either having them ambulating, make sure that we're providing them with privacy if they're going to have a bowel movement, and basically anything that we can do to assist in establishing their regular pattern of elimination or having a bowel movement. So where the problem comes in is patients who are unable to walk to the bathroom or who are actually restricted and are told to stay in bed secondary to procedures or maybe a specific illness or an injury or maybe a specific surgery, may require the use of a bedpan. So here's the two different kinds of bedpans you may see. One of them is a fracture pan, and it is a little bit more shallow of a bedpan, and that's used for patients, especially with hip or back fractures, to help promote comfort in patients who have to basically lie flat for the most part and are unable to raise their buttocks off the bed. So even a regular bedpan, even though it has a higher profile, um, and is a little bit more uniquely shaped, as you can see here, very similar to what we would consider a standard, like a toilet seat. It allows the patient to be raised at a more normal position for elimination. However, either one of these, something that I learned early on was to put them underneath the patient, sometimes to take some baby powder or some kind of a powder and put it around the rim of that, and then you're going to have to push down into the bed and push it up underneath them. So plastic against the skin oftentimes doesn't slide very nice, so sometimes putting a little baby powder on there will help that slide in there. If you put a patient on the bedpan, please make sure that you go back and check on them to make sure that they're done and they're off the bedpan, because you're most likely going to have to um, wipe them and whatnot. So I don't know. There's been times where I've gone in there and someone said, "Oh, can I get off this bedpan? They've been on there for like 30 minutes." So if you do put it on there, put it underneath there. Make sure you go back and take it out. So we we have to be fairly responsive to whatever toileting needs that the patient has, because they're stuck in a bed by themselves, and it's kind of up to us to help them know that if they do have to go to the bathroom, make sure the call bell's in reach, and make sure that if you respond to the call bell is very important. um, I know that when I was in the hospital there for a while, it just seemed like if I hit the button, whether I had to urinate or have a bowel movement, either one, it seemed like it took them forever to come. So when you see a call bell, I always tell my student nurses and the nurses that I used to train, I don't care whose room it is, I don't care who patient it is. If the call bell is going off, you get your butt in there and find out what is going on and if you can be of assistance. And sometimes it may be something as simple as giving them a urinal or placing them on a bedpan, either way. So the other thing is about regarding skin integrity and preventing the pain when the positioning of the patient those are pretty important things. So time on the bedpan should be limited, and that's not only because it's uncomfortable having something underneath there, but it also prevents skin breakdown and decreases sphincter control. We always want to maintain the patient's privacy during bowel elimination. I don't know about you, but I like to be in a room with my door closed and nobody bothering me. And it would be no different than in a hospital. And it's really hard, especially if you have 4 patients to a room or something like that. It's hard to establish that privacy. All you can really do is close the curtain, and hopefully everyone will be quiet and stay out of their way. Bedpans are only used by that patient, uh, and they should be kind of washed and rinsed out and disinfected after each use. This is what we call a bedside commode, and basically it's a portable toilet, if you will, and it has a toilet seat and a receptacle beneath it that can be emptied. The other thing is, we're typically, some of these patients, we're measuring their inputs and their outputs. So some of these, the hats and whatnot that go in there are calibrated so that we can go ahead and we can measure what we have. Stool is a hard thing to measure, so usually we will say, bowel BM times 1 and describe it, whether it's firm or soft or diarrhea. If it's diarrhea, you could probably measure how much. The scary part about a bed commode is that they're going to have to get up out of bed. So if your patient is going to be using this and they need assistance, you should always tell them to, hit the call bell, and you'll come in and help them get onto the commode, close the curtain, and then let them do their thing, and then tell them to hit the call bell when they're finished so that you can come back and empty the commode and clean it and measurement and assessment of what the fecal contents were. So we mentioned earlier how important it is for ambulation after surgery or whatnot, because it does stimulate the peristalsis and helps kind of maintain their regular bowel function. For patients experiencing bowel elimination problems, a return to previous level of function is basically our optimal goal for them. So, in order to achieve that goal, additional assistance may be needed in the form of either bowel training programs, elimination schedules, and consideration of certain medications, whether it be laxatives or things like Colace that increase the bulk of and fluid in the bowels. So all those need to all be considered. So what if someone is having the flip side of constipation? Maybe they're having diarrhea. Then I would consider something like an anti-diarrheal medication, which are used to slow the motility of the intestine and kind of promote the absorption of the excess fluid in the intestine. So it kind of slows things down so that we get more fluid mixed into the chyme, mixed into the bowels, and it also makes for easier passage of that. And those things like the cathartics and the laxatives may sometimes be prescribed when a patient is unable to empty the bowels normally. So it's just basically your laxative suppositories are another thing that are oftentimes effective. Um, and sometimes they're more effective actually than their oral counterparts because of their the stimulant effect on the rectal mucosa. So the nurse basically has to, if you are using a suppository, you need to make sure that the suppository is placed next to the mucosa and not in the stool that's in the rectum. So there is a specific way to put a suppository up there, and basically you want to make sure and take it out of whatever wrapper it is. You're going to put some kind of a lubricant on, and you're going to push it up there with your finger and make sure it goes past the sphincter up into there. And the laxatives basically they work to kind of soften the stool, and in a way it also distends the rectum, which causes them the feel or the need to have a bowel movement. Now with enemas, um, we are basically inserting a certain volume of fluid into the rectum, which rapidly distends the colon and irritates the intestinal mucosal lining, which stimulates the urge to have a bowel movement, and that can affect the whole entire lower intestinal tract, if you will. There are several different types of enema solutions that are available today. One of the ones, probably the more common ones, you would probably hear of today is called like a Fleet's enema, which is about 100 mils of a fluid that you put into the rectum, and you tell them to squirt it up there, or you squirt it up there, and to hold it for as long as you can, and then they're going to feel like they're going to have a bowel movement. There are medication enemas. There are return flow enemas and oil retention enemas, and some of those are mentioned in your book, as well as a pretty descriptive, uh, a pretty detailed description of what each one of those are. So these different types of enemas that we've just talked about uh, are usually anywhere between 750 mils and 1,000 mils of fluid, and these are used especially in your cleansing enemas. Um, Carminative enemas, they use 40 to 60, which is a little bit more of a smaller dose. And in your return flow enemas, is about 100 to 200 mils of solution. And these are alternatively administered and drained from the rectum. So I also worked for he was a colorectal surgeon, and his name was Dr. Bowman, and we used to give patients what we call Dr. Bowman's enema, which had like, if I remember correctly, it had like 100 milliliters of hydrogen peroxide, and then we would mix that with like 300 milliliters of normal saline, and those would work. We'd put those up there, and if you can imagine hydrogen peroxide, I don't know if you've ever put hydrogen peroxide on a wound that's full of bacteria, and those little bubbles happen. Well, that would kind of happen inside of their rectum, and they would have to go have a bowel movement relatively quickly. So there's all these different types of enemas. Some you will see more frequent than others, and it just depends on the situation and the provider as well. I am not going to go in too much into ostomy care because there are wound ostomy nurses that this is their specialty. But overall, we want to maintain that skin integrity. We have to keep our eye on the stoma, make sure that it's nice and pink and it's not necrotic or anything like that, and promote whatever kind of comfort we can for the patient. And hopefully, we can at least, maintain their self-esteem and their dignity because it's a pretty embarrassing thing. So there are a lot of different ostomy appliances that are actually used to protect the skin. They're used to collect the drainage and to control odor. Pouching systems can include one or two pieces of appliances consisting of skin barriers, and then there are the what we call a wafer, and then a collection pouch. And the pouch basically attaches to the abdomen by the wafer, and the wafer is sitting over the top of the stoma, and then they usually clip in. Now, there used to be where the bags were reusable, where you would take the bag and you have to empty it, and you have to clean it and reclip it and put it back onto the wafer. Uh, More recently, though, what I am being told, this is not my specialty, but what I'm being told is they're typically a single use pouch. So when the pouch is full, you take the pouch off and you throw it away and you snap the new bag into the wafer. The 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 wafer itself, or the barrier, basically goes directly over the stoma, and then it protects the skin from any kind of a fecal output, because fecal matter will cause skin breakdown in a very quick manner. So, um, and like I said, there are wound ostomy nurses for that, and they are very good at what they do. And as you slowly get exposed to this, or if you ever take care of a patient with one of these, there are pastes, there's all sorts of different things, there's powders, there's all different ways to maintain that skin integrity. And a lot of times we will be part, if not uh, at least a part of maybe doing some discharge teaching on how that's to happen. But if you do have a wound or an ostomy care nurse, they're certified in this. This is their specialty. This is what they do. And so if you have that available to you, get them involved. And not only will you learn something, but also the patient will also benefit from having them involved in that as well. So this slide just shows like what a stoma looks like. The A picture is what I would consider to be a healthy stoma, where the skin is intact, versus the B, which has excoriated skin. So the skin has either been traumatized or worn away or braided, and this is oftentimes in the presence of maceration, which is due to incontinence exposure to feces. So that tissue that you see in A is basically a bowel either whether it be a small bowel or large bowel, that's been brought out through the skin and turned inside out and then sutured around. And that's what creates your stoma. I did mention about the wound ostomy care nurses, and these people are fantastic, and they should be consulted at any time you have an ostomy. Get them involved in the care early on. They can help teach the patients how to uh, take care of their ostomy, as well as taking the apparatuses on and off, and or emptying them if they need to be, and dealing with any kind of associated skin care issues that can come about. So a patient with an ostomy in place learns self-care, and so it's pretty crucial that this begins early on in their admission or into their disease process. And so the earlier we begin this training, the better off we will be in the end during discharge, or preparing them for discharge. So probably one of the biggest things is that a stoma can cause a disturbed body image. I mean, it's not something that everybody wants everybody to know. So, especially if it's a permanent one, we have to help them through that. And then patients can, they're going to naturally perceive a stoma as, very invasive and very disfiguring. So we have to help them psychologically through that. So presenting yourself in a professional manner and an accepting manner, and letting them know that, hey, look, we get it, but we need to help teach you how to take care of this. You'll get through this, and that there are other people with stomas who made it through this. If it's a permanent one, especially, I mean, they're going to be dealing with this probably for the rest of their life. So, them being involved in the process early on will help the patient build their confidence, and at least give them some sense that they've regained some control over themselves. So, we can refer these patients to colostomy support groups, such as the United Ostomy Association or the National Foundation for Ileitis or Colitis, and there are other ones that are out there. So whatever support group is available, and again, your wound ostomy care nurses would certainly know what those groups are and who's the best one to refer them to that. So, as we've learned I'm probably in all your classes, that the nursing process is cyclical. So after an evaluation, if it's determined that the patient's goals have not been met, we have to review that plan of care and consider revising any of the interventions along the way, especially in this particular case as it relates to their bowel elimination. So maybe it's the patient's current food and fluid intake. Maybe it's a certain medication use. Maybe it's their sedentary lifestyle. Maybe we need to have them increase their activity level, uh, and also what their knowledge is. And I hate to use the thing of a knowledge care or knowledge deficit, because to me that's just kind of a way of saying that they don't know what they're doing, which that might not necessarily be the problem, but maybe it needs to be reviewed, and maybe some teaching needs to be uh, reiterated as far as their GI function goes. So it's very important for us to include the patient in the planning stage early on and throughout the entire plan of care, as we prepare these folks for discharge, because they're going to be on their own, and we want to have some confidence that they know how to take care of their stoma. So for nasal gastric tubes, which is going to be one of your checkoffs for specifically for GI, the nasogastric tube, okay, is typically not used for feeding. I want you to think of the nasogastric tubes. If I ask you what a nasogastric tube is, your answer should be it is to decompress the stomach and rest the bowels. Because that's really what we're doing is we're going to have everything, it's going to go through their nose, down through their esophagus, and into their stomach, and we're either going to have that hooked up to continuous suction or intermittent suction. And the whole idea is to decompress that stomach and rest the bowels. And oftentimes, these are used in patients who are experiencing a paralytic ileus, where their bowels are not, the peristalsis is not happening. And so we don't want anything in their stomach stimulating their peristalsis for a while. So, and that will give the bowels a little bit of a rest to kind of chill out and get together. So, also, if a patient's experiencing irretractable nausea, vomiting, for example, uh, maybe they're just constantly being nauseated. Also, in some certain maybe poisonings and those sorts of things, we're gonna go ahead and put down an NJ tube, and we're gonna kind of decompress their stomach. Which, if their stomach is distended and bloated because things are backing up, then that will help alleviate some of the nausea, vomiting. It's These are typically not used for tube feeding. Okay, if I want to put maybe medications down through there, perhaps in some certain instances, but most likely it's the only thing it's there for. These people are usually NPO, okay, and so they're not having anything by their mouth. So that's exactly what we want. We want their stomach to be emptied. It keeps suctioning even the bile and all the contents out of their stomach and kind of allows everything to just relax for a while. So it's going to be very important for you guys to not only read in your textbook, but also to review the videos regarding the procedure for placement. So once we get the edgy tube placed, um, I need to measure it from the nose to the earlobe to the xiphoid process. And then I usually put a piece of tape around my NG tube so that as I get excited and I'm saying swallow, 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 and I'm pushing the tube and your patient's gagging, I don't get overly excited and go too far, because if you do go too far, all that's going to happen is that NG tube is going to coil up around into the stomach. So there's no real need for that. So if I get to where I need to go up to my measurement point that I had, presumptively, okay, I could tell myself, okay, how do I know that I'm in the right place? Well, uh, number one, maybe I'm going to get some gastric contents out, for example. Or I could take a 2 syringe and hook that up to it and push some air as I put my stethoscope over the epigastrium and see if I can hear a swish of the air. Or though the gastric contents that I get back, I can do what they call a pH test strip, which you would take a little strip of this tape and you put it in there. And if the contents is acidic, it usually turns a green color. And that would basically those are only presumptive, okay? So once I get done, if all those are present, I'm thinking that I'm in the right place. However, the only definitive verification of that process, and to make sure that you're in the right place, and before you do anything else, it needs to be verified by an X-ray. Okay, so that ends the bowel section of the lecture. So let's all go take a break and go for a micturition break. And then the part two of this lecture will include the urinary portion.